renal pathology, renal cyst disorders. All right, so for the renal cyst disorders, I'm only going to be talking about two of them: autosomal dominant polycystic kidney disease, ADPKD, also known as, and then autosomal recessive polycystic kidney disease, ARPKD. All right, I'm going to give you the highest yield things that you have to know, and you're going to crush these. It's so easy, relatively straightforward, and so many different resources spend so much time explaining it. Who cares? At the end of the day, you just need to get the questions right, understand the process, and move on. So first and foremost, we have autosomal dominant polycystic kidney disease, okay? ADPKD. And that AD stands for adult, okay? That's how I remember it. So these patients are going to present when they're older, when they are adults, usually around young adult age, okay? Like 30s maybe, but just keep that in mind. Patients present as adult, AD for adult, ADPKD, okay? And this is autosomal dominant polycystic kidney disease. And it's in the name. You have polycystic kidney disease. You have multiple cysts within the kidney, okay? Now, this is an inherited defect. It's always bilateral, and you get enlarged kidneys with cysts, okay? And it destroys the kidney parenchyma. So as you age with autosomal dominant polycystic kidney disease, you progressively get worse renal function, okay? Now, what you have to know is that there's a mutation in genes encoding polycystine proteins, okay? Poly for parents. That's how I remember it. So poly for the parents. Parents meaning that they're adults. Polycystine is seen in adult or autosomal dominant polycystic kidney disease, okay? And the patient's going to present or associated with Berry aneurysms, mitral valve prolapse, and benign hepatic cysts, okay? The way that you can know this is that you have bubbles in the brain, bubbles in the kidneys, and bubbles in the liver, okay? So you get hepatic cysts, Berry aneurysms, and then obviously the cysts in the kidneys. That's all you need to know. There you go. Lastly, look for a family history of sudden death at a young age. Okay? So once again, autosomal dominant polycystic kidney disease, ADPKD, is for the adults, usually a mutation in genes encoding for polycystine, poly for parents, and you're going to see Berry aneurysms associated with it, as well as hepatic cysts. The patients are going to present with a family history of sudden death. All right? Next is autosomal recessive polycystic kidney disease. For autosomal recessive polycystic kidney disease, ARPKD, the patient's going to be a fetus. They don't get to live because the cysts actually present later on in life. They don't present the cysts actually present in utero. Unlike in ADPKD, the patients actually cysts aren't seen in utero and they present way later on in life in adult years, like 30 years old. Okay, so that's a key differentiation. ARPKD, autosomal recessive PKD, is for the fetuses, okay? Because we could see it literally on ultrasound. And it's a mutation in fibrocystin. So fibro is for the fetus. Poly is for the parents. So fibrocystin is for fetus, autosomal recessive polycystic kidney disease. What are we going to see? If you see a baby with portal hypertension, secondary to congenital hepatic fibrosis, automatically start thinking of ARPKD. Very rare for a baby with portal hypertension to be a thing. All right? And that's pretty much all you need to know. This can cause ARPKD, can lead to Potter sequence, which makes sense because what do we say? Urine produces amniotic fluid. If I can't urinate, like patients with autosomal recessive polycystic kidney disease, ARPKD, if I can't urinate in utero, then I have less amount of amniotic fluid protecting me, and you get the signs and symptoms of Potter sequence. So overall, one more time, ADPKD, autosomal dominant PKD, is for adults. Patients are going to present later on in life with cysts in their kidneys, and then they're going to have Berry aneurysms and hepatic cysts and the mutations in polycystine. For autosomal recessive polycystic kidney disease, the patients are going to present in utero with cysts. They have a fibrocystin deficiency, fibro for fetus, and the baby can have potential liver problems, hepatic fibrosis with portal hypertension. And it can lead to Potter sequence in utero. That's all for the renal cyst disorders. If you have any questions, feel free to reach out.